her medical training at Tufts and completed residencies in infectious diseases, I forget where, but her residency in psychiatry, more importantly, was here at Cornell, Payne Whitney, and that's when we first met many, many moons ago. I will give you the dates on that. While at Payne Whitney, Dr. Shear developed the clinical research program for anxiety disorders that she ran for a number of years, and but then left and went off to the University of Pittsburgh, where she continued that work, doing trials for anxiety and comorbid anxiety disorders, psychotherapy trials. And then in 2006, she was recruited back, and she assumed the Marion Kenworthy Professorship of Psychiatry at the Columbia University School of Social Work. And over these last few years, Dr. Shear has really focused her research in the area of complicated grief, and we're going to be hearing about that work tonight. She completed the first randomized trial of complicated grief therapy, and two of people who have been working with Kathy are going to present their work with patients tonight. Now, one thing I just want to mention is that I was thinking about Kathy and her wonderful career, and there's a real alignment, I think. You can correct me if I'm wrong, Kathy. One of Kathy's missions really aligns with that of NYC CBT Association, and that is the dissemination of empirically supported psychotherapies to mental health professionals, but to an interdisciplinary group. And forever, for as long as I've known her, Kathy's has had tremendous value in working with disciplines outside of psychiatry. So when I first knew her at Payne Whitney, I was a nurse at the time, and I was helping Kathy out with some of her work. And then over the course of a few years, I shifted over to psychology, and Kathy may not remember this, but she was really instrumental in helping me collect my data for my doctoral dissertation, and I'll never forget that. But over the years, Kathy has really worked with different disciplines, really values that, and I think you'll see that this evening. And I was just telling Kathy that our association is very interdisciplinary, so tonight we'll have nurses, psychologists, psychiatrists, marital therapists, family therapists, social workers, just to mention a few, and a lot of students in those different disciplines. So it's a real treat to introduce Kathy and have her come up and talk about her work. So please welcome Dr. Katherine Shear.
Thank you so much, Susan. And I will say that we do go back so far that Uris Auditorium was not built when we met. So, and actually, I did give a talk right before I moved to Pittsburgh. There was a grand rounds on women in psychiatry, and that could be a whole very interesting thing to talk about. But we won't talk about that tonight, because we are going to talk about complicated grief treatment, which, as Susan said, we developed at the University of Pittsburgh. When I went to Pittsburgh, I went to work in anxiety disorders, but someone named Holly Prigerson was there as a postdoctoral fellow, and she was interested in bereavement in older adults, and so she was the one who identified one of the people who identified the syndrome of complicated grief, and they were having trouble treating it. They thought it was a depressive kind of illness or condition of some sort, and they were having trouble treating it with interpersonal psychotherapy, which actually is a wonderful treatment for depression. And so they figured, if it doesn't respond to a treatment for depression, maybe it'll respond to a treatment for anxiety. So that's kind of how I got started in this in 1995, actually. So it wasn't all that recently. It's been I guess that's almost 20 years ago, right? Amazing. So we've now completed 2 randomized controlled trials. The second one is submitted for publication, so I'm going to show you sort of a hint of the one slide that has a little bit of the results, but essentially we replicated the first study. And we have a third one that's underway at 4 different sites. And Nancy and Natalia have both been working with me here in New York. And they're going to talk to you, they're both trained as CBT therapists, and they are going to talk to you about what it's been like to learn this treatment from that perspective. So, but I want to start just by introducing you tonight to the treatment, to complicated grief treatment. And to begin with, you know, death, of course, is something that is quite universal. And we know that 2.5 million people die in the United States every year. 60 million people die worldwide every year. And on average, nobody knows how many people are bereaved. There actually isn't in the literature a definition of bereavement, as in there's not an operationalized definition of bereavement. So there's never been a study of how many people are bereaved by any given loss. But there are some estimates of how many people, how many very close relationships anyone has, and a conservative estimate is about 3 very close friends and relatives. So we use that in trying to estimate this. And so 2.5 million people die every year, and of course once someone has died, they're forever dead. And so this is a cumulative rate. And recently, a couple of years ago, a German psychologist, I think, did an epidemiologic study of bereavement in Germany and found that 60% of the population said they had lost someone important. That's how she determined that. This is Annette Kirsting. So that's another way to think about how many people are bereaved at any given time. And that's, of course, the base rate from which we'll start thinking about complicated grief. So loss of a loved one is obviously a common experience. It's a universal experience shared by all humanity. But one of the things about grief, and this is just, in a sense, ordinary grief, is that it typically leaves us feeling more alone and really more confused and unsettled and emotionally activated than almost any other experience that any of us has. And we know this both from our own experience, from our friends and relatives, and also from lots and lots of novelists and poets and singers, artists of all kinds have been concerned with grief. And this is just this quote from Charles Dickens, I think, is a particularly poignant one, so I like to show it, but it kind of makes that point of how separated you feel, even though you're experiencing something that is the most universal experience of humanity. At the time you experience it, you feel very, very alone. So, in a sense, that's because grief is both universal and also it is absolutely unique, not only to each person who's bereaved, but each relationship that any person is bereaved of. And it's sort of a truism that each person's grief follows a fully unique trajectory, and yet there are commonalities that we're going to talk about in a minute, which I think are very important. And what's also important is that even though it's such a dramatic and very unsettling and very, very activating experience, most of us get through it in some ways in a surprisingly kind of adaptive way. And the quote on this slide is from a book called Strangers to Ourself by someone named Timothy Wilson, who you may or may not know, but he's a social psychologist who works with another social psychologist who's actually better known. His name is Dan Gilbert. And if you don't know Dan Gilbert, you can go on to YouTube and watch him in a very entertaining TED talk that he gave not too long ago, a couple of years ago. And these guys study happiness. They're happiness researchers. But what they've gotten interested in is something they call the psychological immune system, or the adaptive unconscious. And this is the same thing that Malcolm Gladwell has written about in Blink. It's the same thing that John Barge, who worked with some of us here at Payne Whitney many years ago, studies and has studied, called unintended thought. But it's basically the idea that our brains contain a whole sort of compendium of implicit processes that basically mirror everything that we do explicitly, every kind of thinking that we do, and emotions are very much involved in this. And that if we don't get in our own way, we have a sort of automatic way of righting ourselves. This is what Wilson and Gilbert and Wilson have really helped us see. And in this book, Timothy Wilson talks about a friend of his, Carolyn, who lost her mother very suddenly to a heart attack, and they were very, very close, and Carolyn was devastated. And as this quote says, she was sure that she would never get over her grief. And he points out, very rightly so, that in a sense she was right. So 5 years later, she wasn't over her grief. She still missed her mother. She still would have done almost anything to have her mother back with her. But he also points out that the intensity, that feeling of devastation, that horrible disruption that she experienced, sort of subsided, and much more quickly than she herself would have predicted, or that maybe anyone would have predicted. And so, he says, little by little, but more quickly than she expected, Carolyn was the funny, energetic, outgoing person she always was. And so this is also what we usually see. Notice that there's no specific times noted in this slide, and I'm not going to really talk very much about specific times unless you make me, because we don't know really a lot about specific times. But just to give you an overall framework, we're usually, so Carolyn, he's probably talking about a period about 6 months or less. Some people will say a year or two, but within some, I think, weeks to months after someone dies, we stop feeling the really intense activation. So that's what most people do, but not everyone. And so it turns out that somewhere around 7 to 10% of sort of bereaved people overall develop a syndrome that we call complicated grief. Other people are calling it these days prolonged grief disorder. The DSM has decided to call it persistent complex bereavement disorder. Whatever you call it, I wanted to show you I want to show you a couple of people from our Pittsburgh study who were suffering in this way.
My involvement in the treatment was around the death of my mother. However, my husband died about 2 or 3 years later, and I think that really exacerbated the situation. But my mom was almost 85 years old, had really only been ill for less than a month, and she passed away. We were very, very close. I could not imagine living without her. I never really recovered, because her death left this gaping hole inside of me. And although my husband was still alive, he wasn't my mom. So I sort of just kind of wandered around through life. I recall looking out my bedroom window and being a little angry because everybody else in the world seemed to just be going on their merry way as though nothing has happened. I'm thinking, how can you do this? Don't you know that the world has lost somebody, wonderful?
My 19-year-old daughter Jackie died in a car wreck on August 21st of the year 2000. She was out that evening and was told to come home at midnight. She got home about 11:45. She was real excited, asked me if she could go out and say goodbye to one more friend, because we were taking her to college on that Tuesday morning. And she left, and I went to bed, and we got a phone call about 3:15 in the morning, asking us if our daughter was home. So I jumped out of bed and went to her room, and she wasn't there. There wasn't, not a whole lot that I remember about that morning, but other than sitting in total disbelief and didn't want to eat, didn't want to do anything, spent most of the day crying. Felt like somebody had torn my heart out. It was my little girl. Well, as time went on, I found that I wasn't progressing or being able to focus myself on work, on anything that I'd like to do. All I could find myself doing is going to work, getting some work done, going in the back room crying a lot. The more I thought about it, I realized that I wasn't doing anything with my life.
It's been 20 years. My husband died at a relatively young age. He was 53. And I got stuck. I just couldn't move on from that. I just grieved and grieved and grieved. And I thought that somehow that it was my fault that I hadn't been able to diagnose his tumor. So then when he died, there was just this giant hole that just seemed impossible to fill. For years I had horrible nightmares. You know, I'd wake up in the morning and I'd think, no, this did not happen. He's still here. I didn't care whether I lived or died at that point, to be honest, but I had this child. So I would lay on the couch and cry every night, and then I would get up in the morning and I would go to work and do my job, and then I would come home and I would lay on the couch and cry. And I did that for years. That's all I could do. I was paralyzed.
So I like to show these three vignettes because these are three very, very different people and very different kinds of losses, very different time frames since the loss. And you can see that the symptoms that they're describing, nevertheless, are kind of remarkably similar. And that's really what we see, so that we can identify people who are suffering from complicated grief using a fairly simple kind of assessment strategy, which I'm going to show you in a few minutes, although there is not yet really consensus in the field about this, as you may know. So what I want to do in the rest of the time is to, first of all, describe the syndrome, tell you about the official diagnostic systems, they're the ICD and the DSM-5 system, and then really talk to you more about how we approach the diagnosis without having an official diagnosis. All of our work has been done before that, and a little bit about differential diagnosis. And then I'm going to introduce you to the treatment, to the conceptual model that underpins it, and to the objectives that we have, and tell you something about the strategies and procedures. And then I'm going to turn it over to my colleagues who are going to tell you what it's like to basically start to do this treatment. So just to start with, the ICD-11 will propose the inclusion of prolonged grief disorder in the stress and trauma and stress disorders section of the ICD-11. And they will define it as it is here, as in a sort of narrative way: intensely painful, disabling, and persistent response to bereavement, that's what you just heard about, with either pervasive yearning or longing or preoccupation with thoughts and memories of the deceased person, and a lot of associated emotional pain. And you see they also kind of fudge about the duration by saying it's clearly prolonged compared to what would be considered normative in view of the individual's cultural and religious background. And then they have a kind of semi-operationalized definition, which is essentially the same. And then, as by contrast, we have DSM-5 criteria, which are in section 3 of the new manual. And I'm not going to go through these in detail because we've been doing some field trials in our foresight study. We've been doing a field trial of the different criteria sets that have been proposed. These are just the 2 official ones. There are a couple more out there. And what we found so far is that these criteria sets, with the exception maybe of the ICD-11 and maybe one other one, are not performing very well. In particular, DSM-5 is not performing very well. So we're hoping that this will not last, because also it's extremely complex, as they say. And we prefer to have it much simpler. So here's what we've been doing. So first of all, we screen people using a 19-item self-report questionnaire that Holly Prigerson developed in 1995 called an Inventory of Complicated Grief. And when she published her paper, she said that if you score over 25 on that rating scale, you probably had complicated grief. And when we started doing our pilot study, we would see these people clinically, and the ones that were between 25 and 30, we often thought were sort of sub-threshold in severity, so we've been using a score of 30 on the 19-item questionnaire. And then we do a clinical interview, and we have a semi-structured clinical interview. We have a skid-like clinical interview that we use, and we do look, of course, for disruption in some ways of ongoing life or relationships or daily activities. And very often in this condition there's also a disturbance in the sense of self, because of course the people we're closest to, if we have a really good positive relationship with them, then it is the case that our identities are often intertwined with theirs. So when we lose them, it creates a sense of kind of identity confusion of sorts. That's a normal part of grief. But most people then find a way to write that and sort of get in touch with themselves again, and that doesn't persist. But in complicated grief, it very often does. So then we look for the way that we conceptualize this syndrome is that there is prolonged acute grief. So I'm going to make a distinction for you between something we're going to call acute grief and something we're going to call integrated grief in a minute. But acute grief is that form of grief that's very intense and disruptive. But it is an adaptive reaction. But in this case, it's prolonged. But that we haven't bought into the prolonged grief disorder name because we think that there's more to the syndrome than the prolonged acute grief. And basically, the other thing is grief complications. So what we mean by grief complications are maladaptive or dysfunctional thoughts, feelings, and behaviors. They're psychological complications that interrupt or interfere with the natural healing process after a loss. So the prolonged acute grief symptoms are things like the yearning and longing. That's absolutely normal to experience after someone dies. The emotional pain, sometimes even the physical symptoms are very common. Feelings of unreality are common, as are these frequent thoughts and memories of the person who died. Very often, very, very compelling and distracting thoughts that basically make it hard to think about anything else, especially when they're intense and prolonged. And then in terms of the complications, kind of insistent, unregulated emotions, frequent troubling thoughts or ruminations about the circumstances or consequences of this death. Oops, sorry about that. That's the inventory of complicated grief. And dysfunctional behaviors, primarily escape and avoidance behaviors. So the avoidance behaviors are kind of typical phobic type behaviors of not wanting to go to places or do things or be with people who are reminders of the fact that this person is gone. And the escape behaviors are more like, you heard Kathy in the clip, the film clip, talk about how she would just kind of go into almost like a daydreamy state, remembering her mother, thinking about the things they used to do together, like a dissociative state, but escaping from the painful reality of her being gone. And then we do see substance use and suicidality as also maladaptive behaviors that occur with complicated grief. So this is the inventory of complicated grief. And as I said, each item is scored on a 0 to 4 scale from never to always. And it's basically just saying, how are you feeling right now? And it really works very, very well as a screening tool. So we use this, score over 30, and then we do the interview that elicits the symptoms that I just showed you. So just a word about complicated grief compared to major depression. There's a lot of confusion about this, and we could probably spend the whole evening talking about the difference and similarities and differences between grief and major depression. But let me just point out the ones that we think are particularly important in terms of differentiating grief and depression. And they are primarily the existence, not only the existence, the centrality of yearning and longing in complicated grief. This intense yearning and longing, which you don't see in depression, really. In depression, especially with the affect as severe as the people that we're working with, people don't want anything. I mean, and that's really the other main point, is that people with complicated grief typically are able to experience positive emotions. And as we know, depression basically is a condition in which positive emotions are either not present or greatly reduced. So those are the main differences. Of course, the other very big difference is that complicated grief is very focused on thoughts and memories and concerns about the loss itself, and that's again quite different from depression. Though, of course, the mood is similar, the sadness and things like sleep disturbance are not uncommon, and appetite disturbance. So there are reasons why people find the two somewhat difficult to disentangle. And then on the other side of the coin, in a way, is post-traumatic stress disorder, which CG also resembles. There is a triggering event and then an intense emotional reaction, but of course the triggering event is very different. So threat is, of course, exposure to something that is dangerous, as opposed to loss, which is the removal of something that's rewarding. So one way to think about this is that with PTSD, the problem is that you're not extinguishing a fear reaction. And with CG, the problem is that you're not extinguishing a reward reaction. And that's really kind of a different process. So again, the primary emotions are obviously very, very different, because in PTSD what we see is anxiety and fear, whereas in CG we see, again, the yearning and also the deep sadness. Interestingly, Ginny in this film clip talked about nightmares, but we actually collected information about nightmares in our Pittsburgh study again, and I think there were only less than 5% of the people that we saw reported nightmares. And again, you all know that's very, very different from PTSD, where they're virtually universal. So we do see a lot of co-occurrence or comorbidity in these three different conditions, but each of them also occurs, as we know, independent of the other two. But so it's not always a question of either or, it's sometimes both and. But we're used to that. I mean, that's basically what we see with any of the disorders that we work with. So I told you how I got involved in this. Holly came and knocked on my door one day and said, do you think you can help us figure out a way to treat these people? And as Susan knows, I said, of course. Somebody asked me, I said yes. But then, no sooner had I said yes, I realized I had absolutely no idea how to do this, because I, of course, had trained here at Payne Whitney, and that meant that I was trained in psychodynamic psychotherapy, and I was a pretty good therapist, I thought. But when I looked back over the 20 years that I'd been practicing at that point, I could literally count on the fingers of one hand the times that I had worked with anyone who was struggling with grief at all. And I did remember some notable people, but it didn't really help me. So what I did was I went out to the grief counseling community in Pittsburgh, basically to the hospice counselors, and I started meeting with them, and eventually they decided that I needed to co-lead a support group, so they invited me to co-lead a support group, so I did that for a while. And I did the other thing I do when I don't know what else to do, which is to read as much as I possibly could. But, so basically, I figured that I had to figure out how to develop a treatment, and I had been involved in the development of the treatment for panic disorder, so I had some idea of how to start. So, we had to develop a conceptual model, and then figure out what happens, a conceptual model of normal grief and bereavement, and then what happens with complicated grief, and then out of that we could define treatment targets and goals, and then draw upon existing psychotherapy strategies and procedures to address these goals. And then, of course, we had to pilot test that program and finalize the treatment, and then we tested the efficacy in the randomized controlled trial that was published actually in JAMA in 2005. So that's not exactly new news, but then when I came here to New York, I had applied for another grant to study the same, basically to do something of a replication in older adults, because in our first study we didn't have very many older adults, and the demographics of this condition make that very, very important. So they at first decided they weren't going to fund it because I was switching, but then at the last minute they did, and so we undertook a treatment study of older adults here in New York, and that study ended, when did it end? A year ago, right? Just about a year ago. And as I said, the paper is under review at the moment. So let's back up though, because so what I'm telling you is that we had to have a conceptual model of some sort, and I will tell you that the grief field to me, and the bereavement and grief field, is very, very lacking in really any kind of understanding of what is going on when you lose someone really, really close. I did have some ideas about this because I was always interested in separation anxiety. Actually, the one thing Susan didn't mention is that when I left, when I finished the residency, I left Payne Whitney for a year to go work with Myron Hofer, who, if you don't know him, he's a very remarkable man who studied maternal-infant separation in rats. And I have to say that I really hated working with the rats. He loved the rats. I didn't like them at all. But I did learn a lot from him. And he basically, what he did was he showed, actually John Poland from here, from Payne Whitney, also has worked with him for many years. And anyway, Myron's work was focused on what he called hidden regulators of attachment relationships. So I had this history, and actually when I was in medical school, my second year of medical school, I did a psychiatry elective. I was at Tufts, actually, and Tufts had the first unit in their pediatric hospital. It was called a family participation unit. It was the first, this is the 1960s. I'm not that old, but I was very, very young at the time. Anyway, most pediatric hospitals, parents could not be in the hospital with the kids, if you can imagine such a thing. It's shocking. But they had this family participation unit, so I did some kind of study. I can't remember what the study I did, but I learned about Bowlby at that time. So now I'm in Pittsburgh, it's 1995, and I'm thinking, how do we understand what this is? And I remembered that the organizing question that Myron had asked is, how is it that the absence of something causes so much havoc, right? It doesn't exactly make sense. So Myron, of course, had started the process of figuring out what that was, and the absence of, in order to understand the absence, you have to understand what the presence of that something is. And of course, what we know is that, like other animals, and this is, sometimes I show this, this is Roscoe and Surya. If you don't know them, they're wonderful, and you can watch them on the internet, and they're fun to watch. But anyway, like them and other animals, we know, biologically programmed to seek, form, and maintain very close attachment relationships with a small number of other people, and to resist separation from these individuals. We know that the brain attachment system is a kind of biobehavioral motivational system, which is also linked to caregiving and exploration, which I'm not going to say anything about right now tonight, but we do think is also important in grief. And the attachment system, Bowlby said, was basically the underpinnings of it was the attachment working model, which is, in modern day language, brain circuitry. And we know that that brain circuitry includes both positive and negative affect, and it also includes memory, of course, because it's the internal representation or the memories of the person who we are attached to are particularly salient. And we orient ourselves goal-wise to various things in connection with our attachment relationship. So it's also, the circuitry also is linked in some ways to the executive functioning. And in fact, I mean, no one has actually seen this circuitry. Some people are starting to look for it with brain imaging, but it's not very, that research isn't very well developed. But one of the neurobiology researchers, attachment researchers, James Cohen, says that actually the whole brain is an attachment, brain. So that's another way to look at this. But whatever it is, there is brain mechanism for this. That's really what I want you to think about. So again, Bowlby said attachment operates using internal working models. And I think you can think of working models as a form of working memory, in that they are, in essence, a component of executive functioning that uses current input, and draws upon long-term memory as well. And it's used, so the attachment working model is used, like other kinds of working memory, for reasoning, problem solving, cognitive control, and goal pursuit. And the long-term memory that we're talking about with attachment memory, with attachment relationships, seems to be mapped both in specific circuitry and also in a generalized attachment working model. And it's very clear that attachment exists. Our relationships are mapped in our memory in episodic, in explicit memory, both episodic and narrative and romantic explicit memory, and also in implicit memory. And if you ever had any doubt about that, well, obviously Surya and Roscoe would convince you otherwise, but if I ever had any doubt, being with my 20-month-old grandson totally convinced me of this, because he doesn't talk. He's clearly attached. So this is important because now this is work from social psychologists who've been studying attachment now for the last couple of decades, primarily interested in attachment security, which I'm not really talking about right now, but the studies they've done looking at the difference between secure and insecure attachment has taught us that all of these psychological systems, and this is really just convenience, basically, topics. I mean, these were just different things that people have been interested in studying. It hasn't been that systematic, but you can see almost every time someone looks at a psychological function with respect to attachment, it turns out that the attachment security affects it. And that's true of a whole range of physiologic functions as well. So what does this mean? Well, basically it means that the loss of an attachment relationship means loss of important regulatory input. And this goes back to Myron's work with maternity, with infant rats and their mothers. But basically, our attachment, our close relationships regulate us emotionally, psychologically, cognitively, and physiologically. And when they're gone, we notice it. So now let's go to talk about what happens when they're gone. And now we're going to shift back into a sort of clinical realm. And we decided, another area so there wasn't really much of a model. There isn't really much of a model out there for grief. And there's a lot of sort of confusion in terminology. So a lot of the bereavement researchers have proposed that we define bereavement as not the response to a loss, but rather the experience of having lost someone, and grief is the response to that loss. And as I said, we very early on started conceptualizing this as acute grief, which is the early response, the sort of initial response to a loss that as we saw before, it can be intense and all-encompassing, and it's usually transitory because it's usually reshaped over time by the mourning process. And it's reshaped to become integrated grief, which is a kind of it's an enduring form of grief. It's sort of residual in the sense that the symptoms are all very muted. So if I were to ask everyone in the room how many people have lost someone close, just looking around, I would imagine that probably we'd be up around 80-90% of people in the room have lost someone close. And then if we were to go around the room and I were to ask you to talk about that person and to really think about them and talk about them, you would, first of all, be able to do that very easily because you certainly remember them. And second of all, chances are you would feel emotional about it. You would feel some emotion. You would feel sad. You would feel some degree of longing. It wouldn't be like right after they died, but you would still feel that. That's what we mean by integrated grief. And Bowlby defined mourning, some people define mourning as the behavioral manifestations of grief that are influenced by culture. That's a perfectly reasonable way to do it. That's not how I'm using mourning in this talk or how we use it in our work. We follow Bowlby, and this is Bowlby's definition, which was this. He said that mourning is the psychological processes set in motion by bereavement, and he actually said regardless of their outcome, but he later said that when mourning is successful, what we're doing is we're finding a way to acknowledge and come to terms with the finality and consequences of the loss and to re-envision life without the deceased person in a way that has meaning and purpose and the possibility of joy and satisfaction, and also to continue a way of staying connected to that person. And then you see there's a little bit of a hole in this slide, and that's because there's a third form of grief, which is this lasting form of acute grief with the complicating features. So what we're saying is that loss triggers acute grief, which is this characterized by intense yearning and longing and sorrow, feelings very often of, at least early on, of disbelief and unreality are very, very common. The insistent, distracting thoughts of the deceased person, often accompanied by trouble focusing on anything else and sort of forgetfulness. Loss of a sense of self, a sense of purpose, feelings of well-being are all sort of gone for at least some period of time. And there's a feeling of being disconnected from other people and from ongoing life in general. So people kind of wander around feeling lost, and very often feeling a sense of incompetence. So loss triggers, though, in addition to acute grief, an instinctive healing process by which acute grief is reshaped. And this happens as the information about the death is assimilated, that is to say, the information about the finality and the consequences of this loss, the emotional pain, and sort of the emotional pain of the loss and the positive feelings and thoughts about the person are gradually integrated into a sort of bittersweet acceptance of the loss. And by that process, grief is reshaped and transformed so that, as I said, the finality and consequences are accepted. There's a way to stay connected with the person who died and a way to go on with life in which there is at least the possibility of happiness, and that's what we call integrated grief. So what happens in complicated grief? Bereavement again triggers acute grief, but it also then triggers grief complications, which take the form very often of counterfactual rumination, sort of second guessing, which you heard in the video, if you remember. Ginny was saying, I kept thinking to myself, I should have diagnosed him, if only I had diagnosed him. maybe he would have gotten treatment and he would have been okay. So you can see where that's going. It's not going into a place where the psychological immune system is going to be able to kick in, if you know anything about that. So that's part of what happens. It's very common. Excessive avoidance and some compulsive proximity seeking, they usually sort of alternate, are usually present. The ineffective emotion regulation, and sometimes inadequate companionship. We need other people to grieve effectively. And sometimes people are actually hostile and do really egregious things to other people. When that happens, we have complicated grief, which again is the persistence of the acute grief symptoms along with the complications. And we're using the term complicated here in the medical sense of a superimposed problem that interferes with healing. So you can think in terms of a wound that is complicated by an infection or myocardial infarction that's complicated by pneumonia, that sort of thing. That's how we're conceptualizing complicated grief. So what complicates grief, again, dysfunctional, troubling ruminative cognitions, ineffective emotion regulation, dysfunctional behaviors, sometimes social or physical, extreme social or physical environmental problems. So these are the details of that. I think I've just told you all that, so we'll keep going. So now we are going to construct the treatment. So once we have this conceptualization, we're saying that basically there is a natural instinctive healing process and that something is blocking it. So how are we going to treat it? I think it's kind of obvious in a way, right? So that's the natural process, but with complicated grief, we have the grief complications. So if we want to provide complicated grief treatment, we're going to have to resolve those complicating problems, and then we're also going to work to facilitate the natural healing process. So that's basically how we went about doing this treatment. And here are the strategies we used. So we said that to resolve the complications, dysfunctional thoughts are part of the complications. So you all know what we do with that, cognitive therapy. And excessive avoidance, we do exposure-based, we call it revisiting for a variety of reasons. Imaginal revisiting, in particular, is a PE-informed intervention in which we ask people to close their eyes and imagine that they're back at the time when they first learned of the death of this person and sort of visualize themselves in that time, at that time, and tell the story of what happened from that moment forward for about 10 minutes. So we don't do a prolonged exposure. We're not extinguishing fear, right? We don't have fear here. We have a kind of fear of emotions. I guess it's a little bit like panic in that regard, because it's a fear of being so incredibly sad that they won't be able to recover, that kind of thing, or a fear of the reality. But it isn't really, they don't experience it so much as fear, but we do revisiting. And for the emotion regulation, so one of the things that Bowlby pointed out that I think is really very important is that when we're grieving, most of the time, our minds naturally oscillate between confronting the pain and what he called defensive exclusion, or setting it aside. And that oscillation provides us with respite, which he said we absolutely need in order to begin to come to terms with a very painful loss. And during those periods of defensive exclusion or respite, if we have positive emotions, and many people do, and again, if you remember Kathy, when she was thinking and daydreaming about her mother, she was happy. She was feeling positive emotions. Ideally, of course, we don't do that in a dissociative way, but we do it, right after someone dies. People come around, and very often we tell funny stories about them, we tell warm stories about them, we feel positive emotions, and in the moment, in those early moments, we are not really thinking about the fact that they're gone. When we're feeling the positive emotions, we're sort of just thinking about when they were present. But gradually, of course, those come together and become bittersweet. So basically, we're going to entrain an oscillation, confronting the pain and setting it aside. And we're going to do a lot of things in this treatment to try to encourage positive emotions. And we're going to start to try to help them rethink reappraise some of the negative feelings, especially negative feelings about grief that sometimes occur. Okay, so then the strategies for making peace with the painful reality, we use okay, so we need to revise the working model and redefine goals and plans. So these are the specific strategies that we use for each of these, to support each of these natural healing processes. And I'm not going to talk too much about, you can ask questions, maybe Nancy and Natalia will tell you a little bit more about the details of these. But one thing I do want to mention is that we encourage people to accept and respect grief as basically the form love takes after someone dies. And that's important because very often people come to us feeling like they just have to get rid of this grief. The grief is a problem for them. It's a bad thing. But actually, grief isn't a bad thing. And so we need to learn to weave grief into our lives. It's what allows a person we love to be gone, in a sense, and allows us to still love them. And it's not an easy thing to do. It requires a certain kind of faith in ourselves and in the universe, and in other people, and we do need other people. We need a supportive community, we need companionship, and we need others to mourn effectively. Okay, so the other principles we use in this treatment are to provide structure, and we do that in terms of psychoeducation. This is very standard CBT kind of thing, and also in the context of the sessions themselves are quite structured, as I'll show you in a minute. We provide companionship, and we also build support. So we really want to foster a sense of connectedness and a sense of belonging. We encourage self-observation and reflection and self-compassion, which I'll say a little more about in a minute. We cultivate rewarding experiences, positive emotions, and faith in the process of adaptation. And we promote autonomy and competence, and maybe some of you will recognize those as basic human needs as defined by Ryan and Decci. And we also work to stimulate creativity and imagination. So basically, we deliver this treatment in 16 sessions. The first 3, we call them getting started. We work on what we call a companionship alliance. We help the person to start to get to know their grief by using a grief monitoring diary. We do an orientation to treatment, and we introduce one of our signature signature sort of procedures, which is aspirational goals work, which is a kind of procedure derived from motivational interviewing, but we're here referring to long-term life goals. Then we move to the revisiting sequence, which is sessions 4 to 9, where we do the imaginal revisiting exercise that I described a few minutes ago. We do situational revisiting that is very similar to in vivo exposure. We do some memories and pictures work, and we work with aspirational goals. What I was just mentioning, we continue the aspirational goals work in every session throughout the treatment. Then in session 10, we do a mid-course review, and then we have a closing sequence of 5 more sessions in which we do another one of our sort of signature procedures, the imaginal conversation. So we have patient have an imaginal conversation with the person who died, in which they speak to the person, they ask them anything they want, they tell them anything they want, and then they reverse roles and take the role of the person who died. It's actually quite powerful, and I think one of the effective components. We continue the aspirational goals work. We sometimes work on a second loss, and we do some termination work. So that's the overall format of the treatment. A typical session has a beginning, a loss focus, a restoration focus, and an end. And as an overview, again, this is a 16-session treatment with elements from CBT, IPT, motivational interviewing, and maybe some other approaches. It's been manualized and tested in 2 NIMH-funded studies, as I mentioned before. It has a loss focus, which is basically aimed at reshaping grief, sort of helping grief transition or be transformed from acute to integrated grief. We use a grief monitoring diary, the imaginal and situational revisiting, the memories and pictures in the imaginal conversation to do that. And we have a restoration focus, which is focused on remaking life in such a way that the person can feel that they have some purpose and meaning in their life, and also that there's the possibility of joy and satisfaction. Grief monitoring is used for that as well. The personal aspirations and goals work is a key part of that, and also planning and doing rewarding activities. And the situational revisiting also is another one of the procedures that goes in both ways. We do this in a context, as I mentioned, of structure, of providing companionship and comfort and help from ourselves and others, and encouraging self-observation and reflection. Each session, by the way, has some loss focus and some restoration focus. You saw that, I guess, in the previous slide, but that's important because we always, starting in session 2, we first do some kind of loss focus exercise and then some kind of restoration focus. So doing this, as I said, we have 2 studies, RCTs. This was our first RCT. This is CGT, and this is IPT, interpersonal psychotherapy, which, if you know that treatment, it has a grief focus, and it is a very effective treatment for depression. It's not so effective for complicated grief, and this is the under review study, which I can't show you too much more about. But you can see that it's actually a stronger response. So I'm going to end with letting Kathy and David and Ginny tell you a little bit about what happened to them in the treatment. I'm going to try to do that.
It finally dawned on me that just because I have family members who have died doesn't mean that he has forsaken me. So now I can go to church and feel free and feel as though I have a relationship with him. And one of the ways I can establish the relationship and keep it going is to read the Bible, which is something that was real important to my mom. The therapist helped me do some reality testing to help me get past the guilt feelings, like I could have done something, I should have done something to prevent her death. And while I knew that intellectually, she helped me get to the emotional core of it. And we relived that experience, I guess, for maybe 3 weeks. And finally it dawned on, I really did all I could do. Well, that infected all areas of my life. I stopped being so reclusive. I got in touch with people from my past in New Jersey. I started making some plans professionally. I changed jobs. I did a lot of things that I never would have dreamed of doing before.
I can go back to reading. I can socialize again. I can meet new people, and I don't have to tell them that I have lost a child. I can deal with them as we go on. If they ask, I tell them that I still have 2 children. One just happens to have died.
I started taking yoga. So I made friends in the yoga class. We go for coffee, we go for bagels, we talk and talk. And it's wonderful. I mean, I'm human again.
So this is obviously not what we always see, but we see this, as I showed you a minute ago, in somewhere in the neighborhood of 50 to 70% of the people that we have treated, which I think is a pretty good outcome. I have a slide that's summary and conclusions, but I'm not going to do that because I'm going to turn the podium over to who? Natalia. Okay. Unless, I don't know, do you want to take questions before we do that, or should we go ahead and...
Why don't we go ahead and...
Okay. So, and Natalia, you have, let's see, I need to get your slides, right? Use that, or we can...
Good evening. Yeah, these microphones are funny. I feel like I need to bend a little. Hopefully you could hear me okay. So my name is Natalia Skritskaya, and I'm a clinical psychologist. I have received my PhD training from Hofstra University, and those of you who know Hofstra might be aware that it's a very cognitive behavioral oriented program, so I identify myself as a cognitive behavioral therapist. And about 4 years ago, I started working with complicated grief. And it happened by chance, as so many things in life happen, and we don't always give importance to chance sometimes. But anyway, about 4 years ago, I started working with Dr. Shear, and I started learning this treatment, the cognitive behavioral treatment, the complicated grief treatment. Okay, thank you. So when I started learning this treatment, I was very excited about it because it was an empirically supported treatment, and in my training that was very much emphasized the value of empirically supported treatments. I also liked that it was based on learning and principles of conditioning. I felt comfortable with it. I felt that kind of having manualized treatment was something I was familiar with. And if you look at different features of complicated grief treatment, I felt it was similar to cognitive behavioral therapy. For example, the structured format, where there is a specific plan for pretty much every session, and you start the session by setting up an agenda and then follow with the plan. I also like the emphasis of CGT on psychoeducation. That was a piece that was important to me, and it made sense. It also made sense that there were assignments for participants, that there were things people would do in between sessions, because I felt that the work is not only done in session, it's done in between sessions. And the forms itself, again, were familiar. For example, the grief monitoring diary that's used in complicated grief treatment, it's fairly similar to depression monitoring forms. So again, that felt familiar and comfortable. And as Dr. Shear has mentioned, there is a range of cognitive behavioral techniques used in the treatment. And there are also exposure-based techniques. So I thought, great, that's familiar. And this is the slide that Dr. Shear showed. And again, I just wanted to show the similarities. It's the target problems, they kind of neatly follow the cognitive behavioral model where we have dysfunctional thoughts, kind of cognitive piece, there is behaviors, avoidance, for example, and then there is affect part, emotion regulation. And again, the strategies are probably many of them are familiar to you. So I was excited and I thought it's going to be easy to learn this treatment, and it was not completely easy. I came across some challenges. The first, probably the most difficult part was the intense emotions. As I started to administer the treatment, I had to kind of witness the pain of participants, and it was also intensely emotional for myself. And I remember for the first couple of months probably, I was walking, as I started working on the project, I was walking around and I kind of in a slight state of shock, and I kept thinking, how can someone, meaning Dr. Shear, choose to listen to stories of death for a living? And later I got to ask her that question, but it took some adjustment on my part, trying to kind of deal with the saliency of death and the fear that I might be in that situation. I might have to face the death of my loved one, and that was definitely a challenge. And it took some time to think and to adjust with it. And I guess to some degree it's still a process. It's not completely over doing this work. Another part, again related to emotions, was difficulty trusting the process, kind of asking a participant to do a very emotionally provoking the exposure, the revisiting exercise, and trusting that it's going to help them, that we're not just torturing people, that actually there is a benefit that they're going to derive from it. So at the beginning it was challenging because I haven't seen the kind of what treatment does, whether it's actually going to help. Another piece that was somewhat challenging for me was the attachment theory. It's such an important part of the treatment and thinking about complicated grief, yet I was not really prepared with my training I wasn't really familiar with attachment theory. I knew about it abstractly, but I was somewhat skeptical about it, and I didn't know enough. What helped me to kind of get to, I guess, trust in it more and to get myself more familiar with it, one part was the neurobiological research, kind of reading on some studies that show that there are some neurobiological mechanisms related to attachment. Also kind of observing patients and observing my own interactions and close relationships and trying to apply it, and it started to make sense, and it started to kind of help me to apply it in treatment. And then a couple additional pieces of complicated grief treatment is using motivational interviewing approach, which again I knew about but I wasn't particularly trained in, so that was another challenge. And also the goals work, such a prominent position in the treatment to working on patients' goals. That was a new skill. So overall, there was excitement and there were challenges, but I do find doing this treatment very rewarding. And one part is I feel it's making me a better therapist. I thought I was a good therapist before I started this treatment, but I've learned a lot and I definitely expanded my skills. And also, it helped me as a person to be more aware of my goals and my values and relationships and kind of gain another perspective. And finally, it's really gratifying to see people change. When a person gets help with this treatment and they are really better, it's quite rewarding. And in the videos, maybe you've noticed, I think especially with Ginny, there was almost a physical change. If you think about the early video, she was more kind of lost and not really taking care of herself. And then when they showed her outside at the table with having a conversation with a friend, she really kind of looked differently. And sometimes we see that it doesn't happen so drastically and so quickly with everyone, but sometimes it's really a contrast. When the treatment goes well, when revisiting works, it can be quite a dramatic change, and it's really rewarding to see that. So that's my kind of brief experience with learning and administering this treatment, and I'm gonna give the microphone to Nancy, who's done this treatment for longer.
So, I'm not showing any PowerPoint slides, but I do think it's valuable to keep up the reward slide, because what I wanted to talk about today is really the challenges and the rewards of being a complicated grief therapist. And I'm going to give some examples of some of the patients that I've worked with. So my name is Nancy Turrett, and I'm a social worker. And I've worked for the past 27 years at New York State Psychiatric Institute. I've worked there part-time, and I have a private practice on the Upper West Side. And I've worked in a variety of the clinics: the inpatient eating disorders, affective disorders, outpatient depression clinic, anxiety clinic, and the schizophrenia unit. And in 2007, Kathy came to PI. And the doctor who runs my clinic said to me just in passing one day, "Oh, you know, Kathy needs some complicated grief therapists. Do you want to do it? It'll be easy." And I was sort of thinking, well, sure, you know, I'll do something new, not a big deal. I've been here a very long time. I feel like I know what I'm doing. And what happened was I sort of approached this training being very overconfident that I had had a wealth of experience, especially at PI, and I felt I really knew what I was doing. And then Kathy came to PI, and we began seeing these patients, and I sort of was hit for a loop. The first thing that sort of hit me was we were dealing with a topic that was extremely upsetting. And this was a topic that I rarely thought about, and I really hadn't even processed in my own head what happens to a person when they die. So all of a sudden, I was being trained as a complicated grief therapist. I didn't even know the vocabulary. I noticed that when we talked about this in meetings, all the other MDs were very uncomfortable about it. And there was one time when Kathy was talking about doing some advertising, and the head of the depression clinic turned to her in a very uncomfortable way and said, well, what kind of photographs are you going to show? Like how, nobody knew the words or the images or the concepts in terms of thinking about death. So my first patient, no less, was a 9/11 victim. And this was sort of a powerful piece for me because my husband worked 2 blocks from the towers and was traumatized by walking on the Brooklyn Bridge and seeing the planes crash into the towers. So my first patient was a woman whose husband left for work one day, and she turned on the radio and saw the planes going into the towers and thought, what the hell is going to happen? I've got 4 daughters, and it was very, very jarring. So she came into the treatment. She was a training case, and we only had a certain amount of time. So we rendered this treatment in a shorter amount of time than usual, which meant it was very intense. It also meant that I was doing 2 revisitings a week, which was, I don't know who that was more traumatic for, me or her, probably me. But one of the key concepts in this treatment is the revisiting exercise. And it really is the piece that enables the patients to process the finality of the death. And, we've been taught that it really helps the semantic memory absorb this. And everyone we see has not processed the finality of the death. And my first patient, my 9/11 victim, hated this and was very resistant. And one thing we saw quite frequently in the beginning of these treatments was you'd tell a patient, we're going to do a revisiting exercise, and then they would go on and on and on about everything under the sun because it was the last thing they wanted to do. So it was the last thing she wanted to do, it was the last thing I wanted to do, and I didn't know why I was doing it, and I didn't understand the impact and the value of it. So one of the big challenges of this treatment is dealing with these concepts that one rarely challenges or thinks about, and believing in the beginning that these techniques help. And they do help. They're incredible. And now, after doing this for almost 7 years, I see the value of the techniques, and it's easy for me to take somebody on this journey of going through the revisiting exercises and helping them process the death. So I'm just trying to give people a feel of what it was like to be a complicated grief therapist. So by my second patient, I turned to Kathy and I said, I really need an old person. And I thought that this person who was a 9/11 victim was sort of the same age I was, there were a lot of similarities. So my solution was, okay, I gotta get an old person. Because if I get an old person and their husband dies, old people die. This is not such a big deal. But again, I was sort of thrown for a loop because it was a big deal. This person she was 80 years old, and she lost her husband, and she lost the love of her life and her partner for over 40 years. And the way in which she lost him was pretty horrific, and all our stories are horrific. He was in a nursing home, and she really had been with him all the time, and one night decided to go home, and then came back in the morning and walked into his room and said, I'm here. And he sort of fell over, and he had died about 4 hours ago, but nobody on staff knew. So that meant that we were doing a revisiting exercise where we had her see this visual image of like him falling over. So again, that was, for the therapist, that was traumatic. For her, it was traumatic. So by that point, I sort of said to Kathy, okay, you've really got to come in and do this revisiting exercise, because I just really was unable to see the value. And I was very lucky working at PI that I was there a lot of the time, and Kathy was there, so I could have the great advantage of her coming in and doing a revisiting, and then I sat in on one of the treatments that she did. So another one of the challenges we faced was, of course, the intense emotion of these patients. My first protocol patient was a woman who had enormous avoidant behaviors. She sat in her house, in her living room, and wouldn't answer the door, wouldn't answer the phone. To get to our clinic, she sort of ran to her car, put on her sunglasses, ran into the hospital, and sat there and hid from everybody. She avoided everything. She had lost her son, who had just had a little baby, and well, the wife was pregnant actually, and he was starting law school, and he died of a pulmonary embolism. She avoided the state of Pennsylvania because that was where they lived. But to see the intense emotion with her was incredibly powerful, and that was another one of the challenges of the treatment. She had very, very powerful revisitings, and at the end of one session, she turned to me and she said, "How do you do this? How do you listen to these stories?" And I remembered how Kathy had said to me several months ago that you give these people back their lives. And I was sort of still a non-believer, but I said it to her, and she was very, very grateful. And then what happened was people started getting better, and then I became a believer. And then I was really able to enjoy the incredible power of this treatment. And one of the gifts I think I've gotten in this treatment is really that it is an incredibly unique experience to take somebody who is in such intense emotion and take them on a journey in 16 weeks and really move them to a better place, a functional place. And they are so very, very grateful. And I was seeing a patient this week, and the patient turned to me and said, "Gosh, you must wake up in the morning and feel like, you really make a difference in people's lives. You really help them tremendously. And, I sort of wake up in the morning and take it for granted, but it really was another chance for me to reflect on the importance of this work." So there are two things I want to share, and then we can open it up for questions. One was really, how did I handle the intense emotions and the devastating content that I was thrown into? And I'm a photographer, so one thing I did was I took my camera and I spent a lot of time in cemeteries, just walking around, getting comfortable. And I put together this book called A Time to Die. And this is just some visual images of death that I can pass this around and people can look at it if you want to. But I ended up going all over the city. I found graffiti about death. I went to cemeteries. I photographed sunsets on graveyards. One time I went to a graveyard and there was like a grave with all these, dug up with all these flowers and pumpkins and memorabilia. So to me that was very self-soothing to utilize my camera in this way and to sort of visually connect with death. That was one of my strategies that really helped me. There's one more story that I want to share, and then we can open it up for some dialogue and some questions. Another power Another way this treatment becomes so powerful is we visit the loss and we deal with restoration of the self in an oscillating process that mimics successful mourning. And the way we deal with the restoration of the self is in the second session, we're taught to say, if we could wave a magic wand and your grief was at a level that was comfortable for you, what would you want for yourself? And to get people to focus on aspirations, dreams, goals, positive emotions. And I was sitting with one patient, and she turned to me and she said, well, I have no idea. What do you want for yourself? And in this treatment, we're taught to answer honestly questions when we're asked, because people ask us if we've ever really dealt with loss or had anyone close to us die. And so I thought about it for a moment, and I said to her, well, my dream would be to go somewhere like to India and photograph a different culture. And then that night I was sort of thinking about it, and I said to myself, you know, I don't need to go to India. I live in New York City. You know, I can go to all the different neighborhoods in New York City and photograph communities that were different than the one I was living with. So that sparked weekly trips to the different communities. I took some of the research assistants with me, and we ended up on 135th Street and Broadway one summer every Friday night, and we got to know the people in the community. And I made a book. I didn't bring that book in. I should have. I called it Life on Broadway, and the opening photograph is a scene of a bench with a lot of old-timers just sitting on it. And the following summer, we went back to the community, and one of the most colorful people in the community, his name was Danny, he had died. He had fallen off a fire escape, and the community was just so devastated, and they had candles and memorials. And what we did was we got some donations, and we printed up about 100 books of Life on Broadway that was photographs of all the people in the neighborhood, and we did a memorial for him and handed them out. So it was very, very cathartic for the people in the community to have this person remembered in this way, and this person who gave a lot of life to the community. So I've given people a quick sketch of some of my challenges, some of my strategies to work them through, some of the treatment, and some of my patients. So I think we could open it up for discussion.
Yes, first of all, I want to thank all of you for your presentation, for the very courageous work that you're all doing. One of the questions I have, Kathy, about your model, I mean, there are a lot of processes that are involved with complicated grief, loss of meaning, passivity, isolation, avoidance, and that kind of thing. One of the things that strikes me is the issue of rumination. And there's a lot of work in metacognitive therapy looking at how people respond to an intrusive thought. So I was wondering, in terms of the kind of intrusive thought that people have complicated grief, the thought or the memory or the image of a loved one who's lost appears, and the person seems to get sort of hijacked by that thought. And from a metacognitive point of view, you might think there might be a number of factors involved. One is that I have no choice but to think about that thought. Another is I have a responsibility to think about that thought. To be a good person, I have to remember that person. I have to figure out the meaning of what that thought is. So I'm sort of wondering how your approach deals with the ruminative process.
So I would say we probably deal with the ruminative process in two ways. One is through revisiting, because I think we do make the, so that the model that we're working with isn't quite that, because we're working with a model that says that when someone dies, it's, I think it would be a reward extinction model where what you get is an extinction burst, and so you get this intensified longing and yearning, seeking, searching for that person. And if the person then isn't there, that gradually extinguishes, right? I mean, that would be the process. But if you're constantly, if what happens instead of that is either, when that starts to happen, you either go into a reverie of some sort, so that you avoid confronting the reality, then you're essentially saying maybe that person's still here. I mean, at some level, at different levels, you're saying to yourself, I guess the metacognition would be that if only, that's the if only counterfactual kind of thinking that tells you that the person is still here. And so it doesn't allow the implicit processes that ordinarily help us reframe, sort of automatically reframe a situation like this. And it doesn't allow the extinction. So we're like sort of focusing people on that. So when we do that, a lot of this will sort of fall away. So we don't necessarily work directly with the thinking. Sometimes, though, we do see people, I would say more one of the latter things that you said, we do see people who keep saying over and over, who have the idea that if they stop grieving, they are in some way betraying the person, something like that. And then we do basically just some cognitive work around that. I would say, basically, essentially challenge that. But, I guess the other thing is we do these visualization exercises also, and one of them is the imaginal conversation that we didn't talk very much about, but that would probably be another way that we would address this, where that we would ask the person to talk with the person, to visualize them, and, of course, what always happens when we do that is the person says, the person who died, when they take the role of the person who died, they say, you really have to stop acting like this. You have to give up this idea that you're betraying me. If anything, you're betraying me because you're not living your own life, something like that. So I don't know if that answers your question.
I think you're correct about the idea of, what the research on rumination or brooding seems to suggest is that it's a form of emotional avoidance.
Right.
So if I'm thinking and thinking and thinking, I'm not feeling, at least in that moment, and then the emotion sort of, incubates, let's say, during the rumination, and then it comes back as free-floating arousal and anxiety later. So in a sense, your approach is dealing with emotional avoidance,
right,
even though the person is very sad.
Right. Right. Definitely we deal with emotional avoidance.
Thank you again for a wonderful talk. My question was about the exposure. I noticed that you phrased it as revisiting and you were distinguishing it. How do you see it as different from exposure? Are you thinking the mechanism is different? Because in terms of the amount of time allotted,
right,
I noticed you mentioned that.
Yes, the time is shorter. So
right.
I guess one way that we see it as different is that the ultimate goal here is essentially to help people not so much extinguish the emotion, really. It's really to help them be able to find a way that's comfortable for them to think about the death. We want them to be able to think about the death because one of the premises is that the death is obviously a part of life, and if you're going to think about the person who died, and we all do think about the person who died, you're not going to just block off their death. You have to be, at times, the death is naturally going to occur to you, and you need to be able to think about it. So a lot of what we're doing is, it's just not an extinction model. I guess that's the difference. I mean, sort of behaviorally, mechanistically, we are doing something similar, very similar, but I don't know if that explains it.
Right, so would you say that the mechanism of action is sort of disconfirming cognitions, or, in terms of the process that's leading to the recovery?
Well, another piece that we do is we record the revisiting, and then we tell the person to take it home and listen to it once a day, listen to it as an observer, and reward themselves. So what happens is the more they listen to it, the level of emotion comes down, and that enables them to think about different thoughts about it that then they bring back and that we work with. So we're bringing the level of emotion down and generating more cognitive thoughts and helping them become more comfortable with it.
Which is essentially the PE kind of
Right.
thing. Yeah, that part is,
It's still PE,
Yeah.
right?
yeah. I mean, I think,
Because one thing you said was that you're helping them confront the finality of it.
yes, that's what I was
Is
just
there
going to
some-
say, yes,
Is there some
exactly.
just confirmation of the cognition that maybe they're not dead, really? I mean, like, what are you seeing as the sort of the mechanism, I guess?
I guess I have to tell you that slightly embarrassing, but this time of night is not the time my brain works the best. So could you invite me in the morning, and I can probably answer some of these more challenging questions a little bit better. But actually, it had the model. I'll just say this much about it. The model is partly about the implicit memory system, and partly that the idea is that we have to assimilate information into all of our memory systems. So I think Nancy mentioned semantic, but it's actually implicit memory that the revisiting is targeting, and the visualization part of the revisiting in particular, because we know that visualization is a very good way to learn, implicit in the procedural memory and implicit memory system. So that's the sort of hypothesized mechanism. It's obviously not tested.
Sure,
So
of course.
yeah. Do we let him say something else, or we? I guess.
Can I just make a comment? Because I think my guess is that probably one of the factors that's affected is what I would call the patient's belief about their emotion, which I call emotional schema. So here's my thought, for what it's worth, that one is that you're normalizing the experience, you're validating it. With the exposure, they're finding out that the duration of the intense emotion is finite, that they can have the emotion, it doesn't go out of control, that they can have mixed feelings that you're pointing out. You can have joyful feelings about someone who you lost as well as sad feelings, that they don't have to be blamed for what they're going through. In other words, that it's not so much disconfirming beliefs necessarily about finality, whatever. It's that I can have all these emotions, and they can be intense, and they can be awful, and they can be, short-lived. They can last long or not last long. It's sort of putting emotion in perspective in their lives, so that they don't have to avoid the emotion. In other words, you're
Yeah, I don't know. I think that's a possibility. I do think that they are avoiding the finality. They are avoiding accepting the finality of the death itself, and
Which
that
is
there
accepting
is
the
something.
emotion.
Yes, it does entail accepting the emotion. That's true. But I'm not sure. I don't know. Maybe that's the core of it. I don't know. I think there's an instinctive process here. I think part of what's bothering me about what you're saying is that I think there's a process that goes on if we don't interfere with it. And I don't think we fully understand what that is, but I do think it involves, I think it very importantly involves the implicit systems, and I don't think we understand implicit memory or implicit cognitions all that well, or any of that yet. And it may be something very different than we think, but I think all of that is usually recruited in grief, and it's being blocked here in some way. And maybe probably one way is through inability to accept the emotions. I think that makes sense, but I don't think it's always that. So, yes.
Thank you very much for your presentation. Along those lines, I'm interested in what you think about, or if you've done any research or how you see this in your conceptual model, what factors may make some people more vulnerable to developing. You know, what happens along that process where some people resolve their grief and some people, it becomes this complicated grief process. And has there been any thinking about how to identify that and how to identify people at risk and offer some interventions that may prevent it from becoming...
Right, which is what we'd all want to do, right?
Yeah, right.
But, I mean, one thing is that I don't know that it's partly a person factor, but it's also a context and a circumstances factor. So it's a combination of probably some personal vulnerabilities, and we have some ideas about that. I mean, we think that personal vulnerabilities include early attachment insecurity, actually. And in the context of losing a secure and very rewarding relationship. So that sort of prototype we see very, very often. Another thing is many people have 80% of the people we see have a lifetime history of depression or anxiety disorder. So very commonly there's a diathesis. So I think of that as being, as the way that we bias, that end up with biased thinking. So those are and then there's about a twofold increase in prevalence rates when the death is violent, suicide, homicide, maybe even accidents, and death of a child is huge. So that, I think, gets into what I didn't talk about much, but the caregiving system and what it means to, how important it is for us to be caregivers. And of course, there are lots of things about a death of a child, but that does seem to be the highest, at least in Western culture. Maybe not in Eastern culture. Yeah.
There are a lot of aspects of what you presented today that sounded like maturation. One of the challenges of living is learning to live with the death of someone. And a lot of what you described, being able to conceptualize a death in such a way that you can have a variety of feelings and responses to it, rather than just one. And if you stuck in one, sounds almost like developing and observing ego around death. Or the significant loss. It introduced me that a lot of what you're doing sounds so dynamically informed, psychodynamically.
Can't imagine why that would be. It's really only because we're here. If you would come some other place. Did you have a question? Yeah.
First, I want to say I took your class at Columbia University. It was wonderful, and it's really nice to hear the work again. Depth of the days later. It's wonderful work. I wanted to ask you if you've ever worked with children and if children experience might be.
So I have never worked with children. It's because I raised them and I knew better. But actually, there are people working with children, and there are. We did. Nancy did. 15, I think she was 15-year-old, treated a 15-year-old, but there are people, so there's, actually I was just out in the West Coast for a period of time, and the group out there is very interested in doing, they see a lot of trauma, especially, this is Victor Carrion in his group, I don't know if that name means anything to you. David Brent and Nadine Mellum in Pittsburgh have done some work identifying CG in children. It does seem to occur in children. there's a paper out of, I think someone from David Barlow's group did a pilot study of some, oh no, I think that was child loss. That was a perinatal loss, actually. It wasn't a child death. But
And there's the attachment component with obviously the children's lives.
the attachment component with the children,
Yeah.
yes. What were you thinking about that?
So an insecurely attached child with a primary caretaker or a disorganized attachment with a child.
Yeah, so, our model would say that if you have an insecure attachment as an adult to the person who died, you would not likely develop complicated grief. Most people, they have a history of generalized, this gets into generalized and specific attachment styles, and I mean, what is attachment style? It gets a little complex, but I think with kids, I think my understanding is that if a child has an adequate caregiver, a good caregiver, even if whoever they've lost, if there's someone else who can be an attachment figure for them, they basically do okay. But I guess if a child had an insecure attachment style, then maybe they wouldn't be able to attach to someone else, but maybe they would. I mean, basically, people with insecure attachment styles can have secure attachment. So, yes.
I'm an inpatient psychiatrist, and I was very useful. I think I see this with a fairly high prevalence in the work that I do. And my specific question is about the role of medications in symptom management, and whether that enhances progress, inhibits progress.
Right. I mean, that's a really important question. We think it enhances it. We're in the 4th or 5th year of a study. Our foresight study is a study of citalopram with and without complicated grief treatment. So we'll be able to answer that. But we did have a secondary analysis of in our Pittsburgh study. We were not permitted to take people off medication, who are already on it, and so we had about half of the people that we saw were on medication. We did a secondary analysis, and the ones that were on antidepressant medication actually had a slightly better, it wasn't statistically significant, but it was a better outcome. So we think it does help.
What about specific use of benzodiazepines?
Benzodiazepines had the opposite effect in our Pittsburgh study, and given what we're doing, that would be not surprising. But again, that was a secondary analysis. We can't be absolutely sure, but we think antidepressants probably help and benzos probably don't. Yes?
Hi, I'm in the women's program, and I was wondering, in terms of pregnancy loss, has this technique been applied or recommended?
We have done, we have included in our studies perinatal loss. Not so much pregnant. We did have 1 or 2 people in Pittsburgh. I can remember one very clearly, woman who had multiple pregnancy losses and met our symptom criteria, and we did include her. We haven't had a lot of experience, but if you read that literature, you probably know it better than, I'm sure you know it better than I do, but the syndrome, the syndrome of complicated grief is pretty clearly described in women who've lost pregnancies, and certainly perinatal loss. Yeah. Yes. I don't know.
Have you treated anyone who experienced a multiple loss, an accident where several members of the family were killed?
Yes. I'm currently treating somebody who lost 3 daughters in a fire. And what we're doing is we're sequencing the deaths. So we've gone through the first death and we're on the second death now. But what specific question did you have in terms of that?
I just wanted to know if you were doing that as well.
Right, and with a lot of the protocol patients, there were 2 and 3 deaths. And what we do is we start with the primary loss, And then usually around session 11, we can get to the secondary loss. And that loss is processed much quicker. So we have gotten very good responses with multiple losses. The majority of situations have not been at the same time, though. This person I'm working with who lost the 3 girls in a fire, that was all for one occurrence.
Yeah.
The other ones were different occurrences.
I'm talking about, I was asking about the same occurrence.
Right, I'm doing that now.
Thank you.
Yes, I have a comment. Your work shows that you teach people to accept grief and become very friendly with grief, to become friends and understand, the loss and desensitize them to that loss. But my question is, have you worked with people that have had experiences with family members with homicide that is very violent, repeated shooting and decapitation? Or I come from South America, so we have another.
I don't think we've had a case with decapitation, but we have definitely treated people who have died by homicide, whose loved ones died by homicide, and it's
So what did you do the same thing?
We basically did the same thing. I mean, I think sometimes with violent death, homicide, suicide, accidents too, you have PTSD as well as CG. I mean, you can have that actually without violent death also, but if the PTSD is very prominent, then you would probably want to do a PTSD treatment, which is a little bit different first, and sort of because if there's a lot of fear in the story of the death, it's very hard to kind of what we do probably isn't intense enough, I think, for that, and so we would do the PTSD treatment first. Yeah.
Can I just ask, are there any pitfalls in the sense that, did I understand the math right, that you have a 50% success rate, which is a great rate, but let's say somebody relapses on alcohol or something, you would stop the treatment? Are there times when you might stop the treatment?
Yes.
And do something else
Yes.
and then go back?
Absolutely. Or we might not do it.
You might decide that they're not really candidates for it.
Exactly.
Okay. Can you pick that up earlier, though? Because you hinted at it before, that there are people that you think you might not even consider this treatment.
Do you want to comment on that? You've thought about that. So.
Yeah, we've seen some people in our program who had problems with alcohol abuse, and we tried to screen them at the evaluation process, but it didn't always happen. Like we had someone I worked with whom she minimized the drinking, and then when we got closer to the active part of treatment, we kind of really realized that she's not ready, she's not a good candidate for this treatment, because the concern was that instead of experiencing the emotion, she would probably increase the drinking, and that's going to be counterproductive, and the treatment is not going to work.
Would other self-harms be, sort of a roulette?
Yeah, similarly, for example, like borderline features, if somebody is not able to kind of regulate their emotions well, or they're at high risk for suicide, that could be a factor showing that they're not a good candidate for this treatment, so they might benefit from other treatment like DBT or a substance abuse treatment first. But also in this population, suicidal thinking is rather frequent, so it's a kind of fine line to differentiate.
Maybe we'll just take one more question for Dr. Shear and her colleagues.
So you mentioned before that the cognitive challenging component is quite similar to what you see in CBT. But I wonder whether that's straight out sort of more cognitive challenging, or more, do you use more kind of creative ways like role play and chair work and things where you actually get, as I guess, you get the loved one, whether in role play to actually do the challenging itself?
We don't do that usually. We don't do, what we do is the imaginal conversation, but we don't, well, I shouldn't say that. We sometimes do some kind of imaginal, actually primarily if the person was not present at the time of the death, and they have a sort of, and they're having a lot of difficulty thinking about that in any way except that they've totally abandoned the person. That, you know, we might do a visual, you know, sort of a kind of a guided imagery, not too guided, but, you know, get them to revise that story and put themselves, visualize themselves with the person when they died, and have a, you know, and have that sort of redo it in that way. So that's the closest we come. We don't do that very often. Mostly we do either the imaginal conversation. The imaginal conversation we don't do with switching chairs or anything like that. I was just in Norway, and one of the people who was at the workshop I did was someone who does that, you know, who does a lot of chair work, and she was very, very adamant about the fact that we were doing it wrong. So she might be right.
Okay, thank you.